webinar of WorldLeish 7. Before our event in Cartagena, Colombia, from August 1st to August 6th this year. We are already in the countdown to the event, and we feel very happy we are going to meet again with all the leishmaniacs around the world. For the first time in WorldLeish history, and to promote synergies, innovation, and integrated approach, cross-cutting issues in the prevention and control of other major neglected tropical diseases caused by kinetoplastic parasites will be included in the program. This will be highlighted in symposia and poster sessions and advances in Chagas disease and African sleeping sickness, with the aim of identifying opportunities to integrate knowledge, experience, partnerships in the elimination of these vector-borne neglected tropical diseases. Until today, April 27, at 11:59 hours in Colombia, is the deadline for submitting works. We hope that everyone will be encouraged and participate with their presentations. Registration with an early fee will be until May 31st. You can find more information on the website worldleish7.org. Without further ado, I want to say that we feel very honored to close the cycle of the pre-WorldLeish webinars with the presence of Dr. Monique Wassuna, who will be the moderator. Dr. Wassuna is the director of Drugs and Neglected Disease Initiative, Africa Regional Office. She is a physician, an infectious disease and tropical medicine specialist. She holds a Bachelor in Medicine and Surgery degree from the University of Nairobi, an MSc and PhD in Medicine from the London School of Hygiene and Tropical Medicine, and a diploma in Tropical Medicine and Hygiene from the Royal College of Physicians of London. She is well published in peer-reviewed journals. She's the founding chairperson of the Leishmaniasis East Africa platform, which promotes clinical research and capacity building for this neglected and deadly disease. Dr. Wassuna is a former member of the International Bioethics Committee of UNESCO. She has been one of the leading women in science in the Africa continent, carrying out relevant research in Africa for Africans and mentoring many young African scientists. She has contributed to building clinical trial capacities in the region, maintaining strong South-South and North-South partnerships. Her achievements have earned her many accolades, including a Distinguished Neglected Tropical Diseases Research Award from the Kenya Ministry of Health and the Kenya Medical Research Institute, Partnership Award from Kenry, and honored as mycetoma ambassador by the Mycetoma Research Center in Sudan in 2019. For her exemplary advocacy efforts to build awareness of this disease, recently in 2020, she was awarded the National Order of Merit Officer of la Ordre Nationale de Mérite by the French government in recognition for her exemplary work helping people with neglected tropical disease and advocating for better treatments for neglected patients in Africa. Dr. Wassuna also uses her vast clinical trial experience to serve on many scientific boards and technical committees. She is a member of the Kenya Association of Physicians and a fellow of the East Central Southern Africa College of Physicians. Dr. Wassuna is a member of the African Vaccine Delivery Alliance of the Africa Centers for Disease Control and Prevention, CDC. Welcome, Dr. Wassuna. And I give you the floor to introduce your guest today, Dr. Asrat Hailu Mekuria, professor at Addis Ababa University with the topic Leishmaniasis in Africa, Challenges and the Way Forward. Welcome both of you, and thank you very much for accepting our invitation. Please make your questions through the question and answer box. At the end, they will be answered. Dr. Wassuna, it's you.
Thank you very much, my friend Carlos, for that introduction. Good morning, good afternoon, and good evening from where you are in the world. Thank you for taking your precious time to join us in the last pre-WorldLeish 7 series of webinars before the WorldLeish 7 Congress in August this year. Before we start, some housekeeping issues. Please put your questions to the chat and we shall try our best to respond at the end of the presentation during the Q&A session. Our webinar today is on Leishmaniasis in Africa, challenges and the way forward. The presenter is Professor Asrat Hailu, and he is my very good friend and a colleague. We've been friends for almost over 2 decades. And I have the privilege and the pleasure to introduce him to you. My friend, Professor Asrat, is an immunoparasitologist at the School of Medicine at Addis Ababa University. He obtained his PhD degree from the University of Amsterdam at the Academic Medical Center. Professor Asrat has been a successful researcher and a mentor to many young scientists and has won many research grants. Professor Asrat's mainstream research is on NTDs, neglected tropical diseases, particularly Leishmaniasis, malaria, and other parasitic diseases. He's a founding member of the Leishmaniasis East Africa platform, LEAP, a member of the East Africa Consortium for Clinical Research, and a lead scientist at the Center for Innovation, Drug Development, and therapeutic trials. He co-authored over 220 peer-reviewed articles and book chapters. Professor Asrat is a fellow of the Ethiopian Academy of Sciences and a member of several learned societies. He chaired the health working group at the Ethiopian Academy of Sciences for 5 years. It is now my greatest pleasure to introduce and present to you Professor Asrat for his presentation. Over to you, Professor Asrat.
Thank you very much, Dr. Monique Wassuna, for this nice introduction. I would also like to thank the organizers and the chair of WorldLeish 7 for this opportunity. It is indeed a privilege to speak at this event. I would like to share my slides now. We'll see. Are the slides shared?
Yeah, but maybe put it on a slideshow.
Okay.
Mm-hmm. We can see them. Slideshow is down. If you can pull your slide up, yeah, pull it up, then it's down.
No, sorry.
Yeah. Even if you just try with your icon there, it should be fine.
Oops. Wow.
Down, yeah, where you are, yeah.
Yeah. Sorry, it is not yet coming, so I apologize for this.
You can go like up in the left corner.
Roll it up.
It says from beginning and just click on it. Up. where it says
Yeah.
from beginning, up on the left up in the corner, left corner up, next to it, the other one.
From the
Yeah.
beginning.
Has it come?
Yes,
Yeah.
we see it now.
Thank you very
Perfect.
much. Okay,
Yeah.
thank you very much for this opportunity again. And yeah, I will be talking about leishmaniasis in Africa. And the way this talk is organized, we have two parts of it. So in the first part really is run through the features of the disease. And I would do that quite quickly, and then later on save time to discuss really issues related to control and elimination. Leishmaniasis is a disease that is a worldwide problem. You have a variety of skin diseases, but also a systemic disease. This slide shows part of really the skin manifestations, but also in the center you see the life-threatening disease. This disease is caused by parasitic protozoa and transmitted by sandflies, and it's mostly transmitted from animal reservoirs. And in this slide you see one of them. Of course we have others like dogs and rodents, but this slide is showing actually Rhochiroxus. I did summarize the data, the current data concerning the status of leishmaniasis globally, and this data is in the fact sheet of WHO at the beginning of this year. We have visceral leishmaniasis, 10 countries actually reporting 90% of the cases, of which 6 are from Africa, and approximately up to 90,000 cases of VL are reported globally. And a subset of these patients are HIV co-infected. A number of countries are reporting HIV co-infection, but mainly Brazil and Ethiopia, but also in Nepal, in India, this problem is significant. We have cutaneous leishmaniasis, again, about 1 million cases annually. The burden from South America is significant, reporting up to 95% of the cases. We have mucocutaneous leishmaniasis, this problem mainly occurring in 4 countries, Bolivia, Brazil, and Ethiopia. And we have PKDL skin manifestation in visceral leishmaniasis patients occurring during treatment or after treatment. And again, this is a problem in the Eastern Africa region and in the Indian subcontinent. My task is actually to discuss leishmaniasis in Africa, and this is a slide showing the global distribution of cutaneous leishmaniasis worldwide. And what I will do is actually show the features of the disease, region-wise or sub-region-wise. And in this slide, you see we have high burden countries. And just let me remind you that most of the countries, it's less than 50% of the cases are actually reported. And in some countries, this problem is quite severe. For instance, I know that in Ethiopia, less than 10% of the cases are reported. This is not really to blame why the reporting is not taking place. We know this is a tool deficient disease. The diagnostics are complicated, and the reports come usually from specialized centers. And the message is here. In fact, the magnitude of the problem is quite bigger than what we show, in this presentation. If I look at the distribution of cutaneous leishmaniasis, sub-region-wise, here is a map showing the distribution in North Africa with 3 species causing the disease. Leishmania major, by and large, but also Leishmania infantum and Leishmania tropica to a certain extent. In North Africa, we have the 3 species. Leishmania major, largely zoonotically transmitted, infantum as well, also mainly from zoonotic sources. And we have Leishmania tropica, which is possibly transmitted in anthroponotic and zoonotic cycles. And rodents and the domestic dog, but also the gundi play a role in transmission. We have many species of sandflies transmitting it, or Leishmania major is transmitted in North Africa by Papatasi, but we have many species of phlebotomies that transmit Leishmania infantum, and in this case overlapping with visceral leishmaniasis, not only in terms of the species transmitting it, but also geographically. And Leishmania tropica in countries like Morocco, we know that those anthroponotic and zoonotic cycles are taking place simultaneously in the same disease foci, and possibly in that country, there is a representation of the Central Asian and Middle East on one hand, but also, the sub-Saharan type of, cutaneous leishmaniasis caused by Leishmania tropica, which is largely zoonotic. In Western and Central Africa, as you can see in this slide, we have many question marks. This is just to show you, in fact, there is really a paucity of data, and a lot remains to be desired as to what is happening with respect to the epidemiology of the disease. However, anecdotal evidence is showing Leishmania major, infantum, and tropica are actually causing cutaneous leishmaniasis in Western and Central Africa. And in the species of sandflies implicated are Phlebotomus dubowski and papatasi. And cutaneous leishmaniasis in Eastern Africa is a major problem. And we have 3 species in this subregion. Aside from Leishmania major and Leishmania tropica, we have Leishmania ethiopica. It's a unique species which is found in the highlands. Leishmania ethiopica is transmitted by Phlebotomus longipes and Phlebotomus pedifer. These are really highland species. We don't see them elsewhere in the lowlands. And there is a zoonotic source, a typical example of a zoonotic transmission in Leishmania ethiopica. And the parasite causes a variety of skin manifestations. Of course, we have Leishmania major transmitted by Phlebotomus dubowski and papatasi. It's mostly sporadic. Otherwise, it can also occur in seasonal outbreaks, for instance, in Sudan. And Leishmania tropica, finally, we have it in Kenya and also a bit in Ethiopia. Now, moving forward towards discussing visceral leishmaniasis. This slide, as you can see, we have the orange bars and the green arrow showing that, in fact, Africa is actually contributing at the moment the largest share of patients globally. And whereas the achievements in the Indian subcontinent is remarkable, as you can see, the blue bars really declining. And therefore, visceral leishmaniasis at the moment is a major problem in the Eastern Africa region. In the continent, this disease, visceral leishmaniasis, is actually, it's widespread endemic, but there are many localities where we also see the sporadic endemicity. And however, the hotspots are characterized by stable endemicity, and there's transmission from zoonotic, but also from human infected person sources. And history remembers the epidemics in South Sudan, in the 80s. And of course, because of the anthroponotic cycles that really ravaged, thousands and thousands of people in Southern Sudan. In North Africa, again, visceral leishmaniasis is mostly caused by Leishmania infantum, but there is also evidence for Leishmania donovani and tropica to also cause visceral disease. And like we have seen it in this part of Africa, phlebotomin species that also transmit cutaneous leishmaniasis are also playing a role here. And again, donovani is occurrence of L. donovani has been reported, Phlebotomus alexandri implicated in the transmission, but Leishmania donovani transmission is likely to be, zoonosis in this place. However, anthroponosis has been implicated, and rarely we have Leishmania tropica causing the disease. Visceral leishmaniasis in Western and Central Africa, again, we like to learn more about it, and we'll be keen to learn from our colleagues in Western Africa, Central Africa, what is actually the picture today. But Leishmania donovani and infantum have been implicated, and surprisingly, we have sandflies of the Sergentumia species also implicated. This would be nice to reconfirm it by future studies. Now, coming to the Eastern Africa concerning visceral leishmaniasis, this is, I would call it the epicenter of this disease in the continent. We have 6 high-burden countries: Sudan, South Sudan, Eritrea, Ethiopia, Kenya, and Somalia. We have, of course, the disease elsewhere, such as in countries like Uganda. This disease, affects approximately 40,000 cases every year. It's a disease that affects impoverished communities, and mostly it's children that are affected. Some of you remember the taxonomy of Leishmania donovani, in the past. So we had Leishmania ashivali, Leishmania infantum, and donovani stricto for this region. And of course, that taxonomy has been abandoned and not intending to really recall or reinvent the wheel. Now this taxonomy has been abandoned, but I would still like to discuss visceral leishmaniasis as exhibiting distinct, epidemiology. And it is not just an academic exercise, but it has relevance for epidemiology and control. This is one evidence showing, in fact, that the northern and the southern ecotypes are actually distinct. And in fact, the southern ecotype, is more close to the Indian, Leishmania donovani. So this is remarkable evidence, and this can be, in fact, it has been shown by a number of markers. And in fact, we add to that a number of other evidences to actually build on this concept of ecotypes. And I will run through some of them. And the countries have been shown in the map, but we have two different sandfly species transmitting the disease, Phlebotomus orientalis and martini. And, the parasites themselves, when we look at some of the markers, for instance, the zymodins, 137, 36, do exist in the southern ecotype. They don't in the northern ecotype. And we know that 137, 36 do also occur in the Indian subcontinent. And that's why sometimes we refer to the southern ecotype as the Indian type. And PKDL is actually rare or absent. And we get something like 5 patients, every 20 years or so. It's really a rare event, whereas it is common in the northern ecotype. And again, in terms of the disease, natural history, the southern ecotype appears to present itself with, chronic course. And it tends to be more acute in the northern ecotype. And also concerning treatment, the southern ecotype is quite, amenable to treatment by some treatments, especially by paromycin and ambisome, which proved to be difficult to use in the northern ecotype. And we have seen this in our LIP platform, and that's, for instance, in southern Ethiopia, even a single high dose of 10 milligrams of ambisome could be used to treat patients in the southern ecotype. More information, a number of criteria, but I don't want to go through it. But one aspect that I like to point out here is the vector itself. The preferred habitat for Phlebotomus martini in the southern ecotype is really the eroded termites. It's completely different from what you see in the northern ecotype. The main vector, Phlebotomus orientalis, really breeds and rests in deep soil cracks, what we call the black cotton soil in the northern ecotype. But VL generally in the Eastern Africa region is a rural problem. It's not found in urban areas. And so it's really transmitted in extradomestic settings, mostly, but also peridomestic. And those anthropogenic and zoonotic cycles are taking place. It is important to note that in the southern ecotypes, the disease is widespread, and there is a lot of herd immunity. Now, this was really a quick run through of the features of the disease, and I now like to move forward to discuss the challenges and the way forward. Now, if we start with diagnosis, well, the issues are really about access and sensitivity of the currently available RDDs in a nutshell. And what is lacking in visceral leishmaniasis is really an antigen detection test in blood specimens. I have always wished to have a test like malaria, where the HRP2 antigen is used to detect Plasmodium falciparum. This has not happened in visceral leishmaniasis. And other tests like LAMP, other direct tests applicable directly on blood have not been moving forward and for any operational or implementation research. In HIV/VL co-infected patients, the answer we know is really an antigen detection test in blood, and this is not available. And similarly for PKDL and CL, it's again, there are virtually no tests. And so no surprise that countries are not reporting, significant numbers of cases. Now, I like to actually point out to the fact that in the perspective of elimination of visceral leishmaniasis, and what kind of tests do we actually need? And we know that we have to, there are super spreaders and human reservoirs which account for the spread of the disease, and we like to be able to detect super spreaders and human reservoirs, and this test is not available, and this is an area where the academics and stakeholders should be venturing. Treatments, existing drugs for visceral leishmaniasis, most of you are aware that the current treatments, which is antimonials, amphotericin B, paromycin, and the only oral drug methoxyfene, are not really suitable for control programs, and they are the mainstay treatment at the moment. There are lots of toxicities and so on. So the need for urgent, the urgent need for a safe, effective drug is apparent. Now, so that was VL, but for PKDL relapses and VL HIV, I mean, we know there is a problem of treatment. It's essentially because there is no sterile cure, and so we have really recurrences. So this is a major challenge. And for cutaneous leishmaniasis, the main problem is that the drugs are not delivered to the skin, and that's a major constraint. Concerning treatment, the other disease entity, that is diffuse cutaneous leishmaniasis, but also the HIV co-infected patients, are really the incurable disease phenotypes. It's mainly because of the persistence of parasites and the dampened T-cell responses. And I like to point out that in the case of HIV-VL co-infected patients, the key problem is really a problem with CD4 counts, which does not come back, after treatment. And in spite of the fact that patients are receiving ART and achieving good viral clearance. So we still would like to know why the CD4 counts are not coming back and how to deal with it. And as a result of this, we have persistence of parasites in the skin, and patients are readily capable of infecting sandflies and so on and so on. Therefore, this is really a major problem or challenge that I need to point out. Now, therefore, control by and elimination of visceral leishmaniasis by treatments, the current treatments are used for 10 to 17 days. They have done a lot of remarkable achievements because they reduced motility, mortality, morbidity, and they also prevented the spread of the disease. But however, we have not seen a decline in the incidence of the disease. So yeah, so each year we treat 20,000 cases, and we can expect another 20,000 the next year. So what is the impact of incidence is less clear, and therefore, so that remains to be really a main issue, from the perspective of control and elimination. And we are hoping that the new treatments will offer a solution for this, the new treatment, which would be self-administered, safe, and affordable. And like I mentioned, for diagnosis, we also like to treat really the super spreaders and the human, reservoir. And how do we do that is another issue, and is actually a priority. Now, what are the opportunities? Sandfly control. Well, this is really a complex area. We have seen the complexity of the transmission cycles, which call for really, approaches that are varied and multiple approaches. So they have to be tailored to each endemic area. So that's not so easy to achieve. And add to that, the diminishing expertise in medical entomology, which is really a big problem. So sandfly control is a neglected area. Animal reservoir control is another murky area. So particularly the sylvatic zoonosis, the wild animal reservoir control is so complex, and that is so important for the the sub-Saharan context. But our colleagues in North Africa and possibly in Western Africa, perhaps they have some opinion on how to use vaccines and impregnated collars, but also culling, as has been done in South America. We like to learn more about it. But however, the wild animal reservoir control is complex, as I said, and there are really a lot of issues that dictate what tools would be applicable. Control by vaccines, I believe, would be the future, and we know that it can be applied in domestic and sylvatic cycles, and we know we have good biomarkers of protection, which is the Leishmanian skin test, and in real life conditions, but also as in field epidemiological cohort studies, we have seen herd immunity can actually be established even from natural infection. And why can't that be done by vaccines? I don't want to go through all this slide, but if you look at the left bottom, this is data that I tried to compile from Leishmanian skin test surveys done in Ethiopia, Sudan, and elsewhere. There's clear association between high rates of Leishmanian skin tests and low incidence of disease. And there's a good rationale to really consider, vaccination as a way forward. And therefore, particularly for Africa, I believe, the success of VL control and elimination programs can be counted upon availability of vaccines. And I think we have to stop to regard vaccines as a long-term goal. We really need to, devise a short-term goal. And I'm sorry to call the anti-leishmanian vaccines as a Peter Pan of those, infectious diseases. Sorry about that. But again, just to show that vaccines are also neglected. Now, the last few series of slides, this is about really networks of excellence. Monique already alluded to the Leishmaniasis East Africa platform. This is really a specialized platform, mainly focusing on testing new treatments and to a certain extent also diagnostics. Sudan, Ethiopia, Kenya, and Uganda, part of it. It's a very nice network, 19 years now since we started. There's a lot to learn from it. We are really thankful for DNDi for supporting it. We have other networks of excellence, just, I would call them primordial, just starting and not adequately funded though. So we have one which is working on around vaccines for PKDL. And again, Eastern African countries are part of it. We have also the immunoepidemiology and vaccinology, the MRC, NIH funding for this program. Again, a new one to start. We have another one on diagnostics, a quantum pack technology venture, and also multiple partners in this venture. And lastly, it's unfortunate that we are not seeing really the center of excellence for sandfly control. This will be my last slide. Just to remark what are the priority tasks. And obviously, from what we have seen in terms of the challenges and the gaps, the need for capacity building for research and training is important. This is probably best done at the sub-regional level, like you have North Africa, Western Africa, and of course, Eastern Africa. So if we can embed the PhD postdoc program in it and cater for specific training packages in entomology, that will help a lot. And it is high time that we actually map the disease distribution. This is likely to involve, both the sandfly distribution, but also using Leishmanian skin test surveys. So it is important that Leishmanian becomes available. We know that Leishmanian, the technology behind the production of Leishmanian is not complicated and it could be ventured even within the endemic areas. Research and innovation, diagnosis, treatment, and vaccines. I already discussed this. Some of the issues like the antigen detection tests, tests for detecting super spreaders or treatments and vaccines and so on. So enhanced funding for new tools is also, a priority. And we like to see commitments from governments and stakeholders. Without them, our task will be challenging. Thank you very much for listening, and myself and Monique will be happy to take questions.
Thank you very much, Professor Asrat, for that stimulating talk, and thank you for keeping within time. So I'd like to open this up for discussion. And I see already there's some questions in the chat. And maybe I can start with the ones that are on the general chat, and then there's some on the Q&A. Professor Asrat, I think there's a question here from let me see, from Carlos, and he is asking whether, besides xenodiagnosis, are there any markers of host infectiousness? That is one question. And northern, maybe can write them down. Northern Africa isolates identical to those from Southern Europe and Middle East. And then still from him, are there Leishmanian skin test with GMP available currently? And he's still asking more questions. Thank you for these questions. Is there a shrinking of VL as a result in less funding? Is the shrinking of VL in results in less funding for leishmaniasis? I don't understand. Anyway, I hope you get that. I don't know, one of those, if you feel inclined to answer some of them.
Yeah, okay, thank you, Dr. Monique. Let me try to address some of these questions. Yeah, there's, I'm also looking at the Q&A. So if I start from the bottom, there's a question about super spreaders for a disease like leishmaniasis. And this is really an interesting subject that would require another seminar or so. And we believe that especially in anthropogenic foci, there are super spreaders, and that's why I did emphasize on the need to develop tests for detecting them. And there are some data using PCR that, in fact, some of these infected but not yet, people who don't show disease yet, are possibly the sources of infection. And the concept of asymptomatic infection has not really, we didn't build any consensus around it, but I think we sort of have missed the point. And in VL, the VL infection is protracted, and for actually patients come up with symptoms, they spend something like 90 days or so, incubating the disease and transmitting the disease. That aspect has been ignored, and that's why we want to really build on the concept of super spreaders. Evidence for or against zoonosis, yeah, that's an important question, but I mean, we have some evidence of infection in animals. Yeah, you want to go beyond that, and of course, yeah, others, some people challenge this notion of the disease being zoonosis simply because of the absence of evidence. I think absence of evidence is not really evidence, for anthroponosis, but we have evidence of infection. GMP scale LSD, yeah, yes, definitely, this will be really helpful to have. Well, animal reservoirs, yeah, that's just again the same question we have, right? And another question we have commitment.
Okay, so maybe, yeah,
right.
maybe we can then go to the issue of the ecotypes, because these are the first questions that how Professor.
There's a question from Hira.
Hira,
yes.
Is asking how different is the northern and southern ecotypes of Leishmania donovani in Ethiopia?
Yeah, in Ethiopia, in Ethiopia, we have the two ecotypes, and they are not overlapping geographically, so they are quite distinct. And a similar phenomena takes place is also happening in southern Sudan, and the southeastern part of South Sudan is also like the southern ecotype, but the northern part is like the northern ecotype. So it's quite distinct.
But is there a difference continuous in the phenotypes between these two ecosystems?
Well, I mean, epidemiology is completely different, but in terms of the disease, I did mention about PKDL, for instance, if you take it as one phenotype, but also in terms of the incubation period, patients from the southern, ecotype, they tend to present really later after many months compared to the northern ecotype. and PKDL as well, but also lymphadenopathy is rarely seen in the southern ecotype, but it's common in the northern ecotype. So there's, to a certain extent, there's clinical phenotypes are also different to a certain extent, but otherwise epidemiologically they are quite distinct.
Okay, I think our colleague Dr. Sise is also asking a question. Do you think COVID as a challenge in the treatment and control of leash? What do you think?
No, I think this is about COVID. And,
COVID, yeah, not COVID, yeah, COVID.
Yeah, yes, it's COVID, and
yeah, as a challenge.
Unfortunately, we did not see a lot of co-infections, but you know, there are a few reports, and we also reported co-infections, and one fatal case of co-infection in Ethiopia. And however, it has not been a widespread problem, luckily.
Yeah, maybe if I can also add that because we were doing clinical trials at that time of COVID, and there was so much involvement of the ministries of health with the messages that were passed regarding what we should do about COVID, that you know, people were able to listen and take these control measures into account. And as researchers, we also developed some methods which we use to see patients when it's necessary and try to monitor them from a distance. So the impact was not great. Yeah. You have already answered the question of super spreaders. I think the next one, Sise still. What do you think the current commitment of government as a challenge to fight against leishmaniasis? I think that's a good question.
Yeah.
Government commitment.
Yeah, if I can comment, I think, yeah, as for in the LIP, you know, platform, you know, we are really intimately in touch with control programs, and we have actually witnessed, you know, commitments of governments, and but the main problem is that leishmaniasis is tools deficient. It's for the health system, it's quite a burden. You know, you have these complicated treatments and diagnostics, you know, access to it, diagnostics is limited, and so on. All the time they have to struggle to find resources and so on. So given the fact that this disease is tools deficient, you know, we can't blame anyone, you know, especially the policymakers, why, you know, they are not party to it, but they are party actually. And I must say the collaboration is very good, and they have to keep it up.
Okay, thank you. There's another question. What do you think? How effective do you think One Health approaches in the fight of leishmaniasis?
Yeah, actually, in my talk, try to look into the vectors and the animal reservoirs, and it's apparent that One Health approach is a way forward, and we know it's going to be involving future control and elimination programs. It's going to involve multidisciplinary approach, and of course, one of the tools should be, you know, spearheading. We know, for instance, if you have a simplified treatment, it can be a pillar. But vaccines, if they become available, they would be really, you know, spearheading the programs. Otherwise, you know, the various approaches should be integrated together, with also, you know, the involvement of you know, stakeholders, you know, multidisciplinary, you know, stakeholders, you know, from the Ministry of Agriculture and veterinary, you know, people from the veterinary field should be party to this. So there is really room for a multidisciplinary approach. Therefore, One Health approach is appropriate.
Thank you. I think we have another question here, which is talking about, I think you answered this on animal reservoirs for Aaron.
Yeah, I did.
Yeah, that we answered. I think the other one is, we've also answered the issue on Leishmanian skin tests. I think not yet GMP production, but maybe going forward, this is a need that would make a difference. I don't know what you think, Professor Asrat, but I think you already also answered that one.
Yeah.
The issue of zoonosis. Is there good evidence, I think, for against zoonosis of Eldanovani? I think
there is a question from Temi asking about really access to medicines, and
Professor
that is an issue.
Asrat,
Yeah, that is really an issue. This is Temi, and asking, he's referring to really that was EM is produced, by one producer, and it is also purchased, by donors, NGOs, and WHO, and so on. And the problem of access to medicines, and that's why, governments in Africa are struggling with it. And access to tools and medicines is a critical issue. And we know that access is limited, and something has to be done. And yeah, what can we do about that? These, treatments are coming from one source and so on. But yeah, so the main problem of our governments is actually that, medicines and other tools are not readily available.
Yeah, I think access to treatments is a big topic on its own, and even for us, for researchers, for funders, people working in these areas of developing new treatments, it's a big thing to be able to be sure that there is, at the end of the day, the patients that are suffering are getting these medicines that they so much need. So it's a lot of stakeholders involved, and the ministries of health are involved, and this needs to be prioritized. And I know that for sure, even my own institution, Drugs for Neglected Disease Initiative, is taking new interest in, more interest in trying to define access for patients suffering from leishmaniasis. So this is a big thing, a topic on its own, but it's a very important topic. Yeah.
Yeah.
So thank you for that question. A gap of knowledge of epidemiology of leishmaniasis, especially CL, is a big challenge. It's a big challenge also. That's the question. I think you addressed it in your presentation as a gap, but you can respond to Murad Mokni, and I like to specifically just appreciate Murad, because he is one of the people that worked together to put this webinar together. Is from Tunisia. So hello, Murad. Thank you very much for your question. I think Asrat, please answer.
The question was, let me see.
It's, do you think that the gap of knowledge for epidemiology of leishmaniasis, especially CL, cutaneous leishmaniasis, is a big challenge also? And the answer is there, yes.
Yes, it is a big challenge. It's cutaneous leishmaniasis is neglected. It's, partly because it's not really a life-threatening disease, and the resources not available for research and control. There's, to a certain extent, there's a bias towards visceral leishmaniasis, and this whole issue of visceral leishmaniasis. Look at diagnostics, nothing. Treatments, nothing. It's completely neglected, and it's important. Something should happen, to address the major problem of cutaneous leishmaniasis. It's a big burden of disease globally, but also, in North Africa. Thank you very much for that, and to really reflect on your concern about the neglect of cutaneous leishmaniasis.
The questions are coming fast and furious, so we'll try to answer as much as we can, because we're also conscious of the time. So the next anonymous attendee would like to, what is the future of diagnostics for VL? Current treatments are invasive and only existing, and most commonly used rapid. Okay. So what's the future of diagnostics for VL?
And that is actually what I tried to reflect in the presentation. Like, for instance, RK39 seems to be going out of the market, and we have no other alternative tests. And soon we will have to resort to conventional methods. It will be sad to see that. And that's why my call for innovation in research and new tests being developed for, for the health system, but also for the control programs is important. We are in an alarming situation concerning diagnostics. Thank you very much for this.
Thank you, Asrat. Another one is, in your view, what would we need to know in order to design vector controls for VL in Eastern Africa? And I think after that, we'll take one more, and then we need to pause.
Yeah. So, I mean, vector control, we like to learn more about vector biology. And I tell you, this is complicated because of the diversity we have seen here. And we have to open up for innovations from other disciplines. For instance, it's also not really an issue of really the vector biologists. It's also the social scientists, for instance. It's people's livelihood. And we know, for instance, in the northern ecotypes that I discussed, agriculture is actually enhancing transmission, and people are creating new breeding sites. The deep, soil cracks in the northern part of Ethiopia and Eastern Sudan. There's a lot of agricultural activity, and the way we do the agricultural practices should change. And I think we have to open up new avenues of control, vector control, not just really targeting the sandfly, perhaps a different way of, trying to avoid, people from being exposed to sandflies. Thank you.
Okay. There's a question about what can Africa learn from the Indian subcontinent? Can Leish be controlled by existing tools? Impact is compromised by the burden versus the numbers treated by the program. What can we learn from the Indian subcontinent?
There are a few issues we learn from the Indian subcontinent, but also we have to recognize the unique epidemiology of the disease in the African continent. So we have seen it's both zoonotic and anthropogenic cycles really playing a role, and a lot of variation. The diversity of the parasites, the vectors, different ecologies. It's completely different scenario here. So our task in Africa is more complex, and diagnostics are not sensitive enough for this region. Whereas, for instance, RK39 did a good job in the Indian subcontinent, and the treatments did very well in India. But imagine if you could put in place, a short duration treatment using, for instance, ambisome or mycin in the northern part in the northern ecotype, which is difficult situations there. So it's quite a different setting here. And yeah, so we don't think that everything that has been applied in India is really applicable. So we want to learn more about, possibilities of control in our region.
So I think we will not be able to answer all the questions, but I think as chair, I just like to ask one question. Professor Asrat, CL, cutaneous leishmaniasis is one of the most neglected entities. And as you've shown in your presentation, it's endemic in about 16 countries in the continent. It causes disfigurement, stigma, and mental health issues. You have spent most of your life working on cutaneous leishmaniasis and visceral leishmaniasis for many years. What specific ask, if there was a president in this webinar, which there was, or a high-ranking Ministry of Health person, what would you have to ask the policymakers and the researchers and the funders listening to you now? What would be your ask? Just briefly, and then we can close. I can say a few comments, and then we can close.
Thank you, Monique, for this complicated question, but I better answer this question by captions. And for researchers, I like to say enhance innovation. I did point to antigen detection tests in blood. I did mention, alluded to the need for, a test to detect super spreaders and human, reservoirs. I did allude to translational research in vaccines, new treatments for super spreaders, and so on. So we like to ask researchers to enhance innovation. And also for cutaneous leishmaniasis, I did allude to the need for improved delivery system. We want the drugs to get to the skin. So that is for researchers. And for policymakers, well, it's about engaging and sharing data, and perhaps also improving the surveillance systems and the reporting systems. So that will help a lot. And for future planning of a control program, and for investments in one of the the control approaches. For funders, well, what can I say except to say stop the neglect? Thank you very much, Monique.
Thank you very much, Professor Asrat. And so thank you very much to you, Professor Asrat. I think it really deserves a big clap. Well done. You've answered most of the questions and very well. And thank you also to the participants for your active participation. Time is not allowing us to continue. So I would like to just make a few remarks before I hand over to my good friend, Dr. Carlos Costa. As you all know, Leishmaniasis is an infectious disease that's affecting neglected, poor communities in Africa, causing disfigurement, stigma, mental health issues, and even death. And as Professor Asrat has just presented, cutaneous leishmaniasis and visceral leishmaniasis remain the most neglected among the neglected tropical diseases in our continent. People regrettably continue to die from visceral leishmaniasis, which is a treatable disease. So as a continent, I want to recap what Professor Asrat had just said. What should we prioritize? We need to build capacity to address epidemiological gaps where critical data is lacking. This would contribute to the control and elimination of leishmaniasis. We need to understand and collect data on the two ecotypes we have just had in VL in Eastern Africa that Asrat has described. And this will contribute to our understanding of the response to diagnostic methods, treatments, and vaccines for the control of and elimination of visceral leishmaniasis in Africa. We can't forget research and innovation in diagnosis, treatments, and especially new oral treatments and vaccines is critical. This would help in the last mile in the control and elimination of leishmaniasis in Africa. Enhanced funding for new tools for research, innovation, control of leishmaniasis in the continent is urgently needed. Commitment from government, stakeholders, and funders and communities is key. Governments must ensure that the poorest among us and most vulnerable, those at highest risk of leishmaniasis, are guaranteed timely and equitable access to the fruits of scientific innovation. We need to work together to go further on the roadmap to achieve elimination of leishmaniasis in Africa. Our people are suffering and waiting for us to act now. Thank you very much, my good friend, Dr. Carlos Costa, for the communication team, the WorldLeish 7 for the facilitation and contribution to the success of this webinar. And I want to thank very much the chair of the WorldLeish 7, Professor Ivan Velas, for giving Africa opportunity to be part of the pre-leishmaniasis webinars. I'd like also to thank my colleague from Tunisia, Professor Murad Mokni, for his contribution to the putting together this webinar. I thank you all for participating. It's my pleasure to have been your moderator of this session, and have a lovely day. Over to you, Carlos, and thank you again, Professor Asrat, for your wonderful presentation. Over to you, Carlos, for the closing.
Thank you very much, Dr. Hailu, for your interesting talk. And thank you, Dr. Wassuna, for your presence. Thank you to all the participants, and see you soon in Cartagena de las Indias, Colombia. Don't forget to follow us in our social media as at WorldLeish 7 on Instagram and Facebook to learn the latest news on the Congress and send you abstracts until today at 11:59 hours in Colombia. So hurry up. See you. Thank you very much. Have a wonderful day.